right, so welcome to our first series, a part of our finance and health series. We want to thank Triage Cancer for being the uh, facilitators and leaders for this discussion. It's a discussion that we often hear people want to talk about and want to learn more information. So we wanted to definitely bring them out and make sure that this information is available for patients and caregivers to learn more about how they can make better decisions and good decisions when it comes to finances and health. So today we have Monica Bryant, who is the COO of Triage Cancer. And so she is going to walk us through making health insurance decisions to save money. So turn it over to you, Monica.
Thank you so much. I am delighted to be here. But before I get started, I just want to tell you a little bit about Triage Cancer. We are a national nonprofit that provides free education on the legal and practical issues that can arise for individuals who have been diagnosed with cancer and their caregivers. Now, oftentimes when I tell people I'm a cancer rights attorney, I get the question back, well, what's that? Or what's legal about cancer? And my response is typically everything, from what drugs someone can take to treat their cancer, to what insurance has to pay for, to employment rights, to caregiving rights, and everything in between. So we provide this education in a couple of different ways. We host educational events that are all open to the public and are free. One of those events is our Triage Cancer Conference, which is coming up. It will be a 2-day event, totally free to attend. All you have to do is register online. It will be virtual this year. And then we have a number of other materials and resources that I'll be referencing throughout today and that you can find all on triagecancer.org. I will tell you a little bit more about our programs at the end of our time together, but I wanted to lead with that because oftentimes we find that people have questions beyond what we're able to answer in the moment of this session. And I just want you to know that in addition to all of the other wonderful resources that exist in Chicago, Triage Cancer can also be a resource for you and your community. So to get into it, one of the things that you might have heard, especially around the conversation of finances and cancer, is a term called financial toxicity. And this was a term that was coined by researchers out of Duke University. And they used this term to describe or compare the financial impact or burden that a cancer diagnosis can have on somebody to the physical toxicity that many cancer treatments can cause. What was particularly interesting about this research was that they looked at how this financial burden or toxicity doesn't just occur in an acute way while someone's in active treatment, and then once active treatment's over, they're fine. But really, they looked at how there is a long-lasting or long-term financial impact after somebody's been diagnosed. So here we are more than a decade later, and we're still talking about financial toxicity at every conference that we go to. Why is that? Why are we still dealing with it? Sometimes people start with the cost of care, how expensive cancer treatment is. And it is expensive. But from our perspective, when we're talking about financial toxicity to a patient or a caregiver, it's not really about the cost of care. There are other contributing factors. And from our perspective, the most significant contributing factor to financial toxicity is somebody's health insurance status. Now, that could mean not having health insurance at all, but oftentimes what we see is that it's more about not having the right health insurance for you or not knowing how to use the policy effectively. Then certainly the employment changes that can occur after a cancer diagnosis could impact finances, both for the individual who's been diagnosed, but also potentially the caregiver. And then all of the things that happen in life that might impact our finances, like relationship changes or moving, those things keep happening even after a cancer diagnosis. So from our perspective at Triage Cancer, we as a healthcare ecosystem need to be helping people address all, or at least most, of these contributing factors in order to effectively avoid or at least minimize financial toxicity. But health insurance is a complicated system in this country. And a lot of people don't spend a lot of time making health insurance decisions. So it's interesting, a research study was done recently looking at the average amount of time Americans spend on large purchase decisions. So it took about 2 hours of research before someone was willing to, pull the trigger on buying a new television, about 10 hours of research and time spent on making a decision around a car. A computer took about 4 hours. A vacation took about 5 hours. When we looked at how long people spent making health insurance decisions, it was 15 minutes or less. Yet, when we think about the impact of making the wrong decision, which could certainly mean access to care, it could mean that you couldn't get access to care. Maybe you can't get access to care at the facilities or with the doctors that you want to get access to, or maybe you're going to spend a huge amount of money to access that care. People are only spending 15 minutes or less on these huge decisions. But it's understandable why that happens. In order to understand health insurance, you basically have to understand a whole new language that no one ever teaches you. And so when a study was done, it found that 96% of Americans couldn't define the 4 most basic terms used in health insurance. 96% of the people don't understand the words. So if people don't understand the words that are being used, how can we possibly expect people to make the right choices for them or to effectively use their policies? So if you are one of those people that's thinking, well, I don't really understand those words, you are certainly not alone. So to make sure that we are all on the same, level playing field, I wanted to talk about some terms related to costs. So there is a cost just to have health insurance, and that's your monthly premium. You're going to pay this monthly premium every single month, whether you go to the doctor or not. Now, the monthly premium is going to depend on the policy, but it is a fixed dollar amount you're going to pay every month. Then there are some costs that you're going to incur when you actually go and use your health insurance. The first is your annual deductible. And this again is a fixed dollar amount that you have to pay out of pocket before your health insurance kicks in. You could have a plan with a $500 deductible or a $5,000 deductible. But again, you have to pay that first before your insurance kicks in. Once you've met your deductible, then insurance kicks in and covers a percentage. That percentage is referred to as cost share or co-insurance. So here we have 2 words that mean the same thing. And you're going to pay that every single time you get care. So for example, you might have a plan with an 80-20 cost share. Once you meet your deductible, the insurance plan is going to pick up 80%. And you're responsible for 20%. Now, many policies also have an additional payment called a copayment. And this is another fixed dollar amount that you're going to pay every single time you get care. This copayment or these copayments could depend on the plan, but they could also depend on the service that you're getting. So for example, someone might have a plan with a $20 copayment just to see their doctor, but a $30 copayment to see a specialist, and a $250 copayment to go to the emergency room. And so there could be situations where someone has both a copayment and a co-insurance for the same service. Now, one of the most important things I think that everyone should know about their health insurance policy is the out-of-pocket maximum. And the reason is that the out-of-pocket maximum is a fixed dollar amount that represents the most you are going to pay out of pocket per year for your health insurance or for your healthcare, excuse me. So once you get to that out-of-pocket maximum, insurance is going to pay 100% of your healthcare costs for the rest of the year. The way we figure out or get to our out-of-pocket maximum is a math problem. So for some types of plans, you're going to add up everything you pay towards your deductible, everything you pay towards your co-payments, and everything you pay towards your co-insurance. So it's everything you're paying out of pocket except those monthly premiums. So to give you an example of how this all works, meet Dan. Dan has a plan with a $2,000 deductible. It's an 80-20 co-insurance, and he has an $8,000 out-of-pocket maximum. Now, Dan hasn't gone to the doctor at all this year, but he gets into an accident and he ends up with a $102,000 hospital bill. What does Dan have to pay of that bill? Well, the first thing we always have to pay is our deductible, $2,000, which leaves $100,000 left of the bill. Because Dan's met his deductible, his co-insurance kicks in now and is going to cover 80%, and he's responsible for 20%, or $20,000. But because Dan has that out-of-pocket maximum, he does not have to pay the full $20,000. Dan only has to pay another $6,000 because he's already paid $2,000 in his deductible. Once he pays another $6,000 of that bill, he reaches his $8,000 out-of-pocket maximum, and insurance picks up 100% of the remaining bill, as well as any medical care he gets for the rest of the year. So I am not suggesting that $8,000 isn't a lot of money. Of course it is. But when we started looking at the alternatives of what he would have to pay if they didn't have the out-of-pocket maximum, which would be $22,000, or certainly what he would have to pay without health insurance, that $8,000 starts to feel a little bit more manageable. Now, if you would like to hear any of those terms again, or go through this example again, or you know anybody in your life that might benefit from learning those terms, we have that in one of our animated videos called Health Insurance Basics. It's a 5-minute long video. You can find it on our website. It's available in English and Spanish and has closed captioning. Now, it's impossible to have a conversation about health insurance without also talking about the Patient Protection and Affordable Care Act, or ACA, sometimes referred to as Obamacare. This is a piece of legislation that was signed into law on March 23rd, 2010, and it made significant changes to our healthcare system, many of which were game-changing for the cancer community. And one of those changes was around what insurance companies can and can't do with respect to selling us health insurance. So the first thing that it did is it said that when an insurance company is deciding what they are going to charge someone for health insurance, they can only look at 4 things. The first is someone buying an individual plan or a family plan? Of course, the more family members you put on the plan, the more expensive it's going to be. The second is your geographic location, and this is based on zip code. The third is age. So it is true that as people get older, they can be charged more for health insurance, but thanks to the ACA, there's now caps on how much more they can be charged. And that was a significant difference from pre-ACA life, where every year, as people got older, those premiums could go up significantly. There was no regulation on that. And then finally, in most states, if people use tobacco, they can be charged more for their health insurance. So these are the only 4 things that an insurance company can look at when they're deciding how much they're going to charge you for that monthly premium. So what you don't see here is pre-existing conditions, health status, weight. You also don't see gender. So it comes as a surprise to a lot of people that prior to the ACA, women were charged more for the exact same policies that men were getting. So this was really significant. But the ACA went even one step further, and it said not only can you not charge someone more, you can't deny selling someone the policy or covering anything related to a pre-existing condition. And honestly, this was the most game-changing thing that the ACA did, because it really opened up a ton of possibilities for people to access health insurance even after a serious medical diagnosis. Prior to the ACA, people could be denied for all sorts of things that were considered a pre-existing condition. And I don't just mean cancer, I mean high blood pressure or diabetes, severe acne, pregnancy, were all things that could potentially keep someone from being able to buy insurance. And that's no longer a possibility anymore. Now, interestingly enough, some elected officials are actually campaigning on the idea that they are happy with these pre-existing condition protections, but they only mean this second part. They don't want to keep number one. And the problem with that is that if you get rid of number one, it's not actually a protection to me to say, well, you can buy the policy, because without number one, insurance companies can price me out. They can make it so expensive for people with pre-existing conditions that effectively they're not going to be able to buy them. So from our perspective, these two provisions need to stay together to truly continue to be a protection for all of us as consumers. Now, there are 3 places in this country where we get health insurance. Approximately 50% of Americans get their insurance through an employer. People sometimes get their insurance through the government, primarily through Medicare, Medicaid, or military plans. And some people go directly to an insurance company and purchase insurance. Regardless of where someone gets their insurance, the terms we just talked about are applicable or consistent across all these different types of insurance. But I do just want to give you some very high level overview about these different types and some changes that you may or may not have been aware of. So prior to January 1st of 2014, there were a couple of ways to access a governmental program called Medicaid. And the way that someone could access it is by having a low income and a low resource level. So resources are things like bank accounts or a life insurance policy. For an individual, the resource level is $2,000. So if someone has more than $2,000, they're generally not going to be eligible for Medicaid. But it wasn't just about having a low income and low resource level. They also had to be able to walk through one of these 4 doors. And in the cancer community, many times it was through either the breast and cervical cancer treatment program or this door on the left called the Age Blind Disabled Program. Terrible name for a program, but it's what we have. The challenges with that is that sometimes people had resources over that. So maybe they were working and contributing to a retirement account. They got cancer, they couldn't work anymore. They basically had to spend all of their savings before they could get access to this program. The other challenge was that the standard of disability was very, very high. So the ACA stepped in and actually created a 5th door, and this door is just based on income. So for people who have incomes at or below 138% of the federal poverty level, they can access Medicaid. There's no resource test. You don't have to have a disability. It's just based on income. So these original 4 doors still exist, and people might be walking through these doors. It's just this 5th door makes it easier for people who maybe couldn't walk through the other 4 to get into the Medicaid program. The other thing the ACA did was create a new way for us to buy insurance. And so the state health insurance marketplaces were created. Think of these as a shopping mall for health insurance or Amazon for health insurance. What you are buying through these marketplaces are private policies sold by private health insurance companies. Blue Cross Blue Shield, Land of Lincoln, Mass Mutual, any of the companies that are selling health insurance can apply to sell in the marketplace and sell their products to the marketplace. This is not government insurance. It's just that the government built the mall for people to come in and sell their private products through it. So oftentimes people will say to me, well, wait a minute. If it's insurance from a private insurance company, why wouldn't I just go straight to the insurance company? Why would I go through the marketplace? And my answer is there are some added benefits by going through the marketplace. And the first is quality control. So plans have to meet a minimum standard to be able to be sold in the marketplace. So someone knows that what they are buying is at least comprehensive coverage. The other benefits are caps on the out-of-pocket maximums, and there may be financial assistance to purchase the plans. So generally there are 2 types of health insurance financial help through the marketplace. The first is a premium tax credit. And that's going to be money that somebody gets to reduce that monthly premium. The second is cost sharing subsidies, otherwise known as reductions. And that's going to reduce things like the co-payments or the co-insurance, for example. So here's how this works in states like Illinois that have expanded Medicaid. For people who have incomes at or below 138% of the federal poverty level, they'll have access to Medicaid. For people with incomes between 138 and 250% of the federal poverty level, they'll have access to premium tax credits to buy the plan, as well as cost-sharing subsidies to help deal with those out-of-pocket expenses. Then for people who have incomes between 250 and 400%, they'll have access to premium tax credits. And the amount that you get in assistance is going to depend on your household size and income level. Now, sometimes people will say to me, oh, I looked at the marketplace a few years ago and it was still just too expensive. My response back is typically you have to look every single year because things are changing on a pretty regular basis. And this is a fantastic example of that. There were some pieces of legislation passed in the last couple of years that added some financial assistance to the marketplaces. So now people who have incomes up to 150% of the federal poverty level can get access to a health insurance policy for $10 a month or less. They're going to pay $10 a month or less for their health insurance premiums. And then they'll also have access to financial assistance. These laws also added some help on the other end for people who maybe had higher incomes, but the cost of their health insurance was more than 8.5% of their household income. So yes, they earned more, but they were also spending a huge amount on their health insurance. They can get some financial assistance to bring those costs down to 8.5%. These financial assistance options will go through 2025. After that, we don't know what's possible. But the moral of the story here is that people should be looking every single year for themselves and not relying on, friends or family who say it's too expensive, or I looked at it a few years back and it was really expensive. It is worth looking every single year because the options change. Now, the last program I wanted to just briefly mention is Medicare. Medicare is another governmental health insurance program that's available to individuals over the age of 65 or people younger who have been receiving Social Security Disability Insurance, SSDI, for 2 or more years, or who have end-stage renal disease or ALS. Those are the only ways to access Medicare. Now, Medicare is one of those things that we talk about as if it is one thing, when in reality it is multiple things. So if you would like to learn more about Medicare, we have tons of resources, including recorded videos, recorded webinars, and animated videos, and quick guides, and tons of things to read on our website. But I do just want to briefly say that if someone is considering their Medicare options, they might have multiple choices. And there are really 2 lanes that someone can choose to drive in. The first is Original Medicare, where someone gets Part A to cover any hospital or inpatient stays. Typically, if someone has worked and paid into the system, Part A will be premium free. Then they will also get Part B, which is going to be medical insurance. And this is going to cover things like doctor's visits, immunizations, scans, IV chemotherapy, all covered under Part B. Even if someone has worked and paid into the system, they are going to pay a monthly premium for Part B and an annual deductible. Part B also has a cost share. So it's an 80-20 plan, and there's no out-of-pocket maximum. So if someone is getting really expensive chemotherapy and they have Part B, they're still going to probably be paying quite a bit out of pocket. Now, someone driving in lane 1 can decide, well, do I want coverage for other prescription drugs? And this could be any kind of antibiotics or any kind of prescription drug someone might go to a pharmacy to get. If the answer is yes, then they can pick up a standalone Part D plan. And these, again, are sold by private insurance companies. Now, I mentioned that Part B doesn't have an out-of-pocket maximum. So if someone is getting expensive care under Part B, they're going to pay 20% of expensive, which of course is expensive. There's one additional type of plan someone can purchase in lane one called a Medigap plan, sometimes referred to as a supplemental plan. Now, what happens with these Medigap plans is they cover all of the out-of-pocket costs with Part A and Part B. The benefit of driving in lane one is that someone can go to any doctor or provider around the country that accepts Medicare. Whereas in lane two, which is the alternative, also known as Part C or Medicare Advantage plans, are plans sold by private insurance companies that are going to bundle all of your services you get under Parts A and B. Most include prescription drug coverage as well. And Part C plans do have an out-of-pocket maximum. So the most significant difference in my mind are two things. One side has an out-of-pocket maximum where the other doesn't. But the side that doesn't have the out-of-pocket maximum lets you go to any doctor around the country. I admit that was a lot in a really short period of time, but I wanted to at least just mention it because if you have additional questions about Medicare, either for yourself or for a loved one or a family member, please, please, please reach out and avail yourselves of the Medicare resources that we have on our website. We see a lot of people sort of be pushed into a decision and it can have long-lasting consequences. Now, for every type of insurance, there is typically a time of year that someone can enroll for the first time or make changes. When we're talking about someone who gets insurance through their employer, that time of year varies. Employers can pick when their open enrollment periods are going to be, but many will pick a fall open enrollment to coincide with a calendar year start date. Medicaid applications are accepted year-round. As soon as someone becomes eligible for Medicaid, they can apply. Medicare and Marketplace plans, again, have annual open enrollment periods, and they are both calendar year plans. So even if someone picks a plan on day one of open enrollment, the coverage won't start until January 1st. Of course, we sometimes have changes in our lives that result in a loss of coverage or an inability to keep our old coverage. And so with every type of plan we've talked about, there are special enrollment periods. So if someone is losing their coverage, let's say at work, or maybe they're moving, or their family has changed, like a child has been born, that would trigger a special enrollment period where someone could then make those changes or decisions mid-year. So the great news is that we have more choices for health insurance than we've ever had in the past, thanks primarily to the Affordable Care Act. The bad news is we still don't know how we're going to make the choices between those choices. So no one has ever taught us how we're going to actually compare and, make the right decision for us. I'm going to walk through a quick example using the Marketplace, but the exact same analysis can be used whether you're trying to compare two Marketplace plans, whether you're trying to compare two employer place plans, it's clearly the end of the day, whether you're trying to compare, well, do I take my employer plan or do I buy a Marketplace plan? Or even if you're trying to compare two Medicare Advantage plans, it's going to be the exact same conversation. So here we have three plans: a bronze plan at $200 a month with a $6,000 deductible and an $8,000 out-of-pocket maximum, a silver plan with a $275 a month premium and a $2,500 deductible with a $6,000 out-of-pocket maximum, and a platinum plan at $400 a month with a $0 deductible and a $2,000 out-of-pocket maximum. So here's my question to you. Can you tell just by looking at this screen which plan is going to cost me the least, assuming I'm going to hit my out-of-pocket maximum? And the answer is no. You actually have to do the math. And the way that you do the math is you take the monthly premium and multiply it by 12, because that's how much you're going to pay in premiums for the year. Then you're going to add that to the out-of-pocket maximum, because that is what you are going to pay. That is all you have to pay throughout the year. and then the insurance kicks in at 100%. And when I do that for all 3 plans, you can see here that that platinum plan ends up being less expensive at the end of the year by several thousands of dollars. But what happens is, because people are typically not taught what these words mean, they don't always look at the full picture, and they typically get sticker shock looking at just that monthly premium and think, well, wait a minute, why would I spend $400 a month when I can spend $200 a month? And they don't always look at the big picture of that decision could cost you $4,000 roughly. But of course, the cost at the end of the year is only one piece of the puzzle. We also have to make sure we're looking at other pieces too. So typically, out-of-pocket maximums will only count payments made towards in-network providers. So in order to find the right policy for you, you want to make sure that it has your providers, which are, hospitals, imaging centers, labs, are going to all be in network. The same is true for prescription drug coverage. So before someone picks a plan, we suggest that they actually look at the drug's formulary, which is just a name for a list of drugs that the plan is going to cover. And actually, I suggest that, especially with certain types of cancers where there is sort of a known treatment path, for example, with certain types of breast cancer, it's pretty common someone is going to be on tamoxifen for 5 years. Making sure that if you are on a course of treatment like that, you've communicated with your healthcare team so that you can check that the drugs you're currently taking are on the formulary, but also any drugs that you are anticipating taking in the next year as well. Now, I know that that was a lot, again, in a short period of time, but we have lots of resources to help people pick a plan, including an animated video that's available in English and Spanish, and our health insurance comparison worksheet. This is one of my favorite resources at Triage Cancer because I think it is something that anybody could use, even if they don't have a cancer diagnosis. You can print it out and actually fill in the different blanks, and then it shows you how you can do the math based on the type of plan you have. I'm showing you a picture here of the worksheet someone could use if they have individual insurance that they purchased or employer-sponsored insurance. We also have a version if someone is trying to compare their Medicare options. Now, getting health insurance is only half the battle. Then we have to make sure we're using our health insurance effectively. And frankly, they don't make it easy to do that. So once someone receives treatment, any kind of treatment, they could get multiple pieces of communication. So just from the insurance company, they could get a letter in the mail saying, we've received a claim. Then another notice saying, well, now you're processing your claim. And then finally, you're going to get the explanation of benefits, or the EOB. And this is one of the most valuable things for people to be paying attention to. An EOB usually is identifiable because somewhere in big letters, it will say, this is not a bill, because it's not. It is just an explanation of what's been billed and what the insurance company is saying they're going to cover, and an estimate about what you are responsible for paying. There's going to be some information about who the patient is. You should see information with dates about the exact service that was provided. Now, this is our illustration of what we think is a gold star explanation of benefits. We wish everyone looked like this because it's easy to understand. It even has words on it, so we know what the service is. Not all EOBs do. But you can see in section 1, it's talking about the service somebody got. In section 2, the green part, it's showing, well, how much was actually charged by the provider and how much is the insurance company going to pay? And then section 3 is based on all of that information. How much are you, the individual, going to have to pay? Now, one of the reasons I say this is sort of a gold star version is because you can see down here at the bottom, it has some additional information. Like how much have you paid year to date for your annual deductible? And how much have you paid towards your out-of-pocket maximum or your family's out-of-pocket maximum? This information is not included on every EOB, and so sometimes it can be challenging to know where you are. Now, the last piece of communication is going to be the bill, and that's going to be from the provider, whether that's the lab or the hospital or the doctor's office. The major challenge to us as consumers is that these pieces of communication don't always show up in this order. And that's true because oftentimes the provider is much faster at processing the bill or sending you the bill than the insurance company is at processing the claim. So the rule of thumb is you shouldn't be paying any healthcare bills until you've gotten the EOB from your insurance company. However, this should not happen in a vacuum. So if you get an EOB, or excuse me, if you get a bill and you haven't gotten the EOB yet, call the provider and just say, listen, I got your bill. I haven't gotten an EOB yet. Can you push back the due date? Or can you make a note in my file that we're waiting for the EOB? That way the provider knows what's going on. And the reason we say this is if someone pays the bill before they get the EOB and insurance has processed it, they are probably going to end up overpaying that provider and then be in a situation where they're trying to get money back from the provider. And while providers might send you the money back, it could take a long time for all of that to be sorted out. And all that time, that money's not in your pocket where you can be using it. If someone is having a challenging financial situation related to medical bills, then they may want to ask at their hospitals if they're eligible for something called charity care. So there are many hospitals around the country that are required to provide a certain amount of charity care to eligible individuals. But how would you know? How would you know if you're eligible? We have a partnership with a fantastic nonprofit called $4, and they have a system where you can go in and put in your information and information about your medical bill, and then they will actually make a determination or screen to see if you're eligible for charity care, and then they'll actually help you with that process. Sometimes people are having a challenge because the insurance company said no. They said, no, we're not going to cover your medical bills. And in that case, we want to make sure that people aren't taking no for an answer. As consumers, with every type of health insurance I've mentioned today, we have the right to appeal that decision. The details do vary based on the type of health insurance, but if you have employer-sponsored insurance or an individual policy that you've purchased, you're generally going to have at least 2 levels of appeal. The first is an internal appeal, where you go back to the insurance company and basically say, please reconsider. The second level is something called an external appeal. And this is where you can go to an independent entity and have them look at the situation. So they're going to look at your plan, they're going to look at your medical situation, and they're going to decide if the insurance company should cover the service or not. Now, the downside to this is here we are asking an individual who may be dealing with cancer treatment to do one more thing in this appeals process, and it can be frustrating and a lot of paperwork and a lot of conversations. However, we know that somewhere between 40 and 60% of all appeals are decided in favor of the patients. So when we take a step back and look at that statistic, what that means is roughly half the time when the insurance company says, no, we're not going to cover that, they're getting it wrong. So we want to make sure that if people are getting denials of care, they aren't starting with financial assistance, because that's generally not going to meet all the need, but rather that they're appealing the decisions so that the insurance companies are paying for what they should be paying for. There are many challenges with the appeal system. One of those challenges is knowledge. So when we look at just 1 year of denied claims, 48 million claims were denied. 99.9% of them were never appealed. But remember, about half the time, the insurance company is getting it wrong. So when we're talking about decisions that you can make to save you money around health insurance and financial toxicity and access to care, this appeals process is incredibly important, yet really underutilized. This is definitely a soapbox issue for us at Triage Cancer. So we have lots of resources to try to help people navigate the appeals process, including quick guides and a tracking form, a module that talks about all the different types of appeals processes, and animated video. So certainly if you think these would be helpful, please do feel free to share them with your communities. Another resource I wanted to mention is our medical bills tracking form. So this is a spreadsheet that you can download off of our website to your computer. And when you download it, you can put in information about your health insurance plan. So you're going to put in information about how much your deductible is, how much your out-of-pocket maximum is. And then as you start to go to the doctor and receive bills, you can add lines in for those expenses. You can see here, there's also information where you can say, does it need to be appealed, or how did I pay for it? As you start adding in lines of medical bills that you're getting, this spreadsheet will start deducting how much you have left to pay for your deductible and your out-of-pocket maximum. And so this tracking form can be incredibly helpful, particularly if you have one of those insurance policies where they're sending you EOBs that are not keeping track for you. But also, it can be helpful for you to keep track of, have you met your out-of-pocket maximum or not? Because then when you go to the doctor and the doctor says, we'd like our $30 copayment, please, you can respond with, I've actually met my out-of-pocket maximum, so I don't need to give that to you. And even if they aren't quite sure, my general way that I deal with that is I just say, you know what, I'm sure I've met my out-of-pocket maximum, but when you run it, if you find out that I still owe you that copayment, no problem, just bill me. Those bills never come because I keep track and I know when I've met my out-of-pocket maximum. And again, we're in a situation where the money now stays in my pocket as opposed to the doctor's pocket, and then they're going to send it back to me at some point in the future. I mentioned that getting health insurance is only half the battle, that we have to make the most of it. And so certainly using in-network providers whenever possible, asking for prior authorizations. So we haven't talked about that yet today, but prior authorizations is a system that we have where you actually have to go to the insurance company before you get services and ask if they're going to approve it or not. In situations where someone fails to get a prior authorization, that could result in a denial of coverage, even if they would have covered it had you gotten the prior authorization. We also need to be paying attention to bills to make sure they're accurate, that we are only being billed for things that we have gotten. We want to make sure we're leveraging those out-of-pocket maximums. So now that we have a better understanding of what they are. And what I mean by that is, maybe if someone's met their out-of-pocket maximum, they could think about, well, is there any other medical care I need in the year? Sometimes we get tunnel vision, especially when dealing with something serious like a cancer diagnosis, and we're focused on only dealing with that at this moment. But if someone's already met their out-of-pocket maximum, maybe thinking about, oh, you know what, I've had this bad knee for years, but I haven't wanted to pay out of pocket for an MRI. Maybe now's the time to go get your MRI because it will be free. It could also be about timing of treatment. So we had a situation with a woman who came to us who was diagnosed in the later half of the year, and she delayed her treatment a few weeks so that she could have Thanksgiving with her family. What ended up happening then is the last couple of treatments were now in the new calendar year. And so she had to pay 100% of those treatments because she had to meet her deductible all over again. Whereas if she had just started a little bit earlier, all of the treatment would have been in the same calendar year and covered at 100% because she had already met her out-of-pocket maximum. So these things aren't always feasible. Sometimes we don't have a choice when treatment starts or ends. But to the extent that we do, and we can make some decisions around that, understanding these out-of-pocket maximums and how to leverage them can be quite powerful. And of course, if you receive a denial of care, make sure that you are appealing that denial. So I'm going to open it up for questions in just a minute, but I wanted to just remind you that we have our upcoming Triage Cancer Conference. This is a free 2-day conference open to anyone who would like to attend. It's going to be all online, so you can join us from the comfort of your home. We cover the most common topics that we talk to people about, including around advocacy and health insurance, being prepared and estate planning, employment rights. We do provide continuing education for nurses, social workers, and patient advocates. And again, this is open to anyone who would like to come. They do not have to have a cancer diagnosis. Caregivers are welcome. Healthcare professionals are welcome. Anyone is welcome. All you have to do is register on our website. We know, though, that carving out a day or 2 full days can be challenging. And so we also have monthly webinars where we, in approximately 60 to 90 minutes, do a deeper dive into one topic. Our next one is our estate planning webinar. Again, these are totally free to attend and anyone is welcome. We also record these webinars and archive them on our website. So if you've missed a topic or you want to go back and hear it again, you are welcome to watch the recording. And then finally, we also know that we can create all of the materials and resources and videos and events in the world, and people are still going to have questions about how this information applies to them. So to address that need, we have our legal and financial navigation program. And this is where anyone can fill out a simple form on our website, tell us a little bit about what's going on, what questions they have. When they complete the form, they'll get an email with a link in that email to schedule a 30-minute call with us. We call you at that time. We generally are going to have to ask some more questions, and then we're going to try to explain your options and walk you through your next steps that you need to take. So we don't provide financial assistance or legal representation, but what we find is more often than not, people don't actually need a lawyer. What they need is to understand the law. And that's what we try to do through our navigation program. This is also available in English and Spanish. So I'm happy to open it up for questions. You can either, Tarnika, you let me know if you want people to come off mute or the chat box, but I will also just remind you that next week we'll be back again talking about employment.
Yeah, feel free to come off mute if you have any questions. I don't know why every time I hear people talk about insurance, it feels like a new topic.
Because it's complicated and it's set up to be complicated. And
Yeah.
you know, we always say at Triage Cancer there should be a class in high school on
Yeah.
health insurance and finances.
I was actually just thinking, like, I've had insurance since college and I still am learning how to use it. So
Yeah, you're not alone. 96% of Americans. Well, hopefully this helped just a little bit.
yeah, if any questions, it's going to leave you guys a couple more seconds if you want to take yourself off mute for questions. If you don't have questions this week, come back next week with your questions, and Monica will be back and we'll be talking about how to do the balancing act of work and dealing with treatments for cancer. And I think people who have gone through not even cancer, or just any kind of health issue, it's a hard thing to balance. So feel free to share with others the upcoming events, and we hope to see you all next week.
Thank you so much.